Hello, everybody, and welcome to another in our Spotlight series. This evening, we're going to be talking and listening to Dr. Yaghi, talking about living your best life with DBS therapy. Many of you have probably heard Dr. Yaghi before, and you know what a delight he is to listen to. Well, you are. This talk is sponsored by Abbott, and the person who is the representative for Abbott is also here this evening, and that's Samantha Summerford. She's wonderful. If you all ever have to have DBS, I think you would probably end up dealing with her some. So now we can get started. Thank you. Enjoy.
Thank you, Judy. Thank you, Michael and Samantha. What a wonderful opportunity to be able to present to this great group and talk about one of the things that's near and dear to my heart as a movement disorder specialist is how to provide patients with a procedural treatment modality such as deep brain stimulation. It's an important discussion, but with DBS comes a lot of hope and positivity about the way we can really take control of symptoms when the medication options and the regimen doesn't really provide us with that stability, and how it is that we can do exactly what we see here in the title is living your best life with deep brain stimulation, DBS therapy, and how we do that. I love the fact that we have this great team, Judy, Sam, and Michael here as we present, because it really is a team approach together with patient advocacy groups just like MAPS, with the Abbott system. We're going to talk about some unique characteristics of the Abbott system and how we can really utilize deep brain stimulation and who's the right candidate. And we'll just have a really important, informative discussion about deep brain stimulation. Let's get started and hear Olson's story.
Uh-oh.
Let's see. Hopefully the sound is there.
Sleep at night, most of the time I sleep 2 hours by day. And so I went to doctors time and time again, and it took 3 years to fully diagnose with severe Parkinson's.
I think we may be having some trouble with the audio, but essentially what Olson's story is it's a patient that's like many other patients that decide to make that step, to take that surgical treatment step and start the process. And really it's a journey of deep brain stimulation. Essentially Olson's medications weren't working like they once did, and we were on a roller coaster ride. The roller coaster ride of Parkinson's disease that we talk about, with dyskinesias and wearing off in between doses, despite trying to optimize medications and adding medicines and trying our combination therapy, rational polypharmacy, all the things that we do as clinicians to fine-tune our treatment algorithm. So today, let's talk about Parkinson's disease, how it's diagnosed, how we treat the motor symptoms, and then how DBS manages those symptoms. So as an academic neurologist, you see Georgetown behind me. This is my my high definition Zoom background with Georgetown here. This is where the fellows go. We don't let the fellows out until they're fully trained after a 2-year training in movement disorders. But the goal of our training is to really understand how is it that we can take care of our patients in the United States, about 1 million patients with Parkinson's disease. We know 60,000 or so are diagnosed every year. And it's probably an underestimate, but about 7 to 10 million worldwide. Again, Parkinson's disease is the fastest growing neurologic disease. And we're going to have to find a way to come up with more presentations like this and treatment algorithms and treatment options and new technologies for Parkinson's disease. So how old are patients when they first get diagnosed? The average age is around 60, but I can tell you my youngest patient when I diagnosed her was in fact 27 years old. So the age range can vary. We can have it as far as in our 80s and 90s or as early as in our 20s. And the idea there is that how is it that we can evolve our treatment options with an always evolving condition? Parkinson's disease, it's true, it does progress over time, it evolves, but that doesn't mean that we don't evolve our treatments, right? We have to come up with different ways to treat. It's a slowly progressive disorder. It's more common in men than women, but it absolutely can affect people from all walks of life, from all economic backgrounds, all social backgrounds, geographic backgrounds. You know, I really like this statement. There's no geographic boundaries. You know, there's no there's no countries that have more Parkinson's than others. All humans can have Parkinson's disease, and it can happen idiopathically or in a hereditary fashion. So this should be something that we come together as a world, as an earth of people together, clinicians and scientists and technology people, technologists, and companies to come up with different solutions to target the real cause of Parkinson's disease, which is low dopamine, right? We know it's a neurodegenerative disorder, but how do we treat patients? We try to augment dopamine. We try and stabilize dopaminergic treatments or non-dopaminergic treatments. But the whole goal here is, this is a DAT scan you see on the top right, where you see those comma-shaped structures. The DAT scan is called, it's a dopamine active transporter scan. And the way we treat Parkinson's disease is to, if you see on the bottom right, you see essentially that there's, rather than those comma-shaped structures, that part of the brain is called the striatum. That's the part of the brain that refines movement. But because of those, rather than have two comma-shaped structures, you have two period-shaped structures. That indicates that there's a loss of dopaminergic cells, dopaminergic neurons, and less transporters around the striatum, which indicates that we see a diagnosis of Parkinson's disease. You know, the hallmark features of Parkinson's disease, many people think it's tremor, and it's true, resting tremor can exist, but only half the time. And that's probably why Parkinson's disease is such an under-recognized disease entity, is because a lot of the time, rest tremor doesn't exist. Actually, in fact, the way we diagnose is with bradykinesia, slowness of movement, in addition to gait impairment or tremor or stiffness. By the time that happens, we've probably lost about 75% of our dopaminergic neurons, because we remember all of the non-motor symptoms of Parkinson's disease that exist that can predate the motor symptoms by decades sometimes. Things like fatigue, sleep dysfunction, loss of smell, constipation, weight loss, among other things. REM behavioral sleep disorder and depression and anxiety are also non-motor features that can predate the symptoms, the motor symptoms that happen. So when we see a patient with loss of sense of smell, constipation, REM behavioral disorder, acting out our dreams, we may predict in the future that we might start seeing slowness, rigidity, tremor. And as the condition progresses, remember, things evolve. And so we might start seeing the drug-induced dyskinesias that occur. Diagnosing Parkinson's disease can be challenging. There is a drought of movement disorder subspecialists in the country and in the world. At Georgetown, we do our best. We have a big fellowship program. I'm one of the attendings that try and teach our fellows about really taking care of our whole person, using that cura personalis approach of really kind of focusing our attention not just on one thing, not being kind of focused just on the motor symptoms, but also the non-motor symptoms, and understanding that this is a dynamic process. It's a dynamic condition that takes big ears, people that listen, doctors that listen and ask good questions and put on their investigator cap and our reporter cap, and we ask really targeted, important questions, screen for things like wearing off, in addition to our motor examination. Think about the newer therapies, our oral medication options, the different types of medicines that are now available for Parkinson's disease, and provide all the diagnostic testing that's important. Another important piece to diagnosing Parkinson's disease is recognizing whether or not someone is levodopa responsive. And that also is very important in determining whether or not someone is a DBS candidate. So it's not all medicine, even though I have an MD after my name, and I'm an allopathic doctor. It's not all drugs, right? It's not all surgeries. In fact, it has a lot to do with wellness. And that's where Judy and Michael come in to teach all of you about all the different options that there are aside from medicines, and medicines, of course, but things like diet, right? How is it that we augment our diet and optimize it to make our brain health as best as it can be? How do we ensure that we're using the right medicines in combination with the types of foods? We know the protein interaction that can affect the levodopa absorption. We know that the MIND diet, MIND, which is the Mediterranean diet, all around the Mediterranean, North Africa, Levant, Southern Europe, all of those places that do tapas-style food and lots of vegetables and fruits can be very, very helpful for our patients, and has been shown, that specific diet has been shown to improve brain health. So don't forget the hummus, okay? Hummus is good for everybody, so don't forget. So exercise also is very important. We think about moving and how that can help. And that's our goal, is to not just utilize diet, nutrition, and exercise, but also consider how is it that we can replenish the dopamine stores in between the synapses to help with providing that dopamine level so that Parkinson's symptoms are well controlled. So you're not necessarily on the roller coaster ride. We know that levodopa converts when it crosses the blood-brain barrier into dopamine. And they'll see those blue dots. Those blue dots essentially are dopamine. And so levodopa is given, it converts in the brain to dopamine, and then it acts on the next neuron and improves symptoms. Of course, we know about dopamine agonists. We know about COMT inhibitors. Dopamine agonists are dopamine imposters. COMT inhibitors like entacapone or opicapone are medicines that help prolong the duration of benefit after each dose of levodopa. MAOB inhibitors, which is another class of medicine like rasagiline, selegiline, and safinamide, are also used as monotherapy or as adjunctive meds. And what they do is they block the breakdown of dopamine so that there's more dopamine within the synapse. That place between neurons, you can see it's like your arm and your fist together. That's the connection, that network of neurons. And between those neurons communicate with chemicals. And those are the chemicals that we utilize to treat Parkinson's. And you can see this goes far back to the 1800s and then the early 1900s, the first synthesized dopamine. We know about the movie and the book, The Awakenings, about the discovery of levodopa. Levodopa was first discovered in the 60s, but then later carbidopa was added to levodopa, called it Cinemet without emesis in the 1970s because so much nausea was occurring with just levodopa. Carbidopa helped reduce the breakdown of levodopa in the blood. And COMT inhibitors were added in the 90s. In the 2000s, you see all of those different treatment options. In the 2010s, before the 2020s, look at all the things that happened before 2020. Look at the type of growth we've seen. It's incredible, and it's very hopeful. Thinking about extended release formulations of dopamine agonists, extended release formulations of levodopa. We have a continuous a carbidopa, levodopa, and enteral suspension, a gel of levodopa that's delivered continuously through the GI system through a PEG-J infusion port. We have inhaled levodopa. We have injectable apomorphine. We have alpha-2A antagonists. They're called A2A antagonists, which is what estradiol is. So we use all these medicines in combination to treat Parkinson's. So this is an example of what a day might look like for a patient that has ups and downs, dyskinesias and wearing off. And what happens over time is you might take your medicine at 7, but probably by 11, it's gone down. And you might take your next dose and it comes up and then it comes down. So if you take your dose at 11, probably by around 5 p.m., as you see there, you're falling below the threshold of some symptomatic control. So that up and down, that ebbing and flowing, the peaks and valleys tend to continue to progress as Parkinson's progresses. So in advancing Parkinson's disease, you see there is an unpredictability in the levels of levodopa. And that difficulty with predicting whether or not levodopa is going to peak or valley makes it so much harder. You can have midday off experiences where we have a return of symptoms. You can have dose failures where you might take your medicine, as you see there around the 3 o'clock time frame. you take your medicine, but it never really gets absorbed. It never really peaks, and then it never helps with symptoms altogether. The other thing is about levodopa is that it's a relatively short half-life. Because it has a short half-life, it doesn't last long in your body. It's not a perfect drug, and so it has to be given regularly. Let's look at this patient who has a distinct difference between on and off. Let's take a look. So you can see him, he's sitting down, and he's essentially showing us how he's walking down the hallway. He has a big smile on his face. He's able to almost run down the hallway. I don't think that was a video malfunction, Sam. I don't think so. But that was really fast, let me tell you. Now let's look at him when he's walking in an off state.
Mm-hmm.
You can see his steps are, his stride length is diminished. He's likely shuffling a little bit. He probably has a reduced arm swing, as you see there. You can see the reemergent tremor in his right hand as he's walking. Now let's see what dyskinesia looks like. Unfortunately, you can see his right side is a little bit more affected, as you could see with that tremor. And when he becomes dyskinetic, he loses control. He has those uncontrollable movements. And so these are the roller coaster rides of Parkinson's. If we could keep our patients in an on state all day long, that is our goal, right? As a movement disorder specialist, my joke of 34 years, including preschool, finally to become a movement doctor, our goal is to keep things steady. How do we fine tune, add medicines here, use on-demand treatments? How do we incorporate surgical treatment modalities when our patients are on that roller coaster ride? Or in a patient that might be on medicine, many symptoms improve, but a good candidate for deep brain stimulation may not only be a patient with on and off, but might also be a patient that has a treatment refractory tremor. Some patients feel their medicine isn't working, but the medicine's working to help people move, but the tremor is still there. And it's hard to control the tremor despite any treatment modality, oral treatment modality, any medicine. And so DBS, in fact, is a good option for a patient like that as well. So what can I do? What can we do as patients and care partners and people within the world of Parkinson's care? Writing things down, believe it or not, can be incredibly effective. Going to your treatment care team and saying, hi, look what I did. And I always think about, in fact, one of my patients who came in and had several days documented every hour. And I know that can be tedious, but it's so helpful. Green check meant I feel good, I'm on. Red check meant I'm off and I don't feel good. And then it was purple. A purple check meant I'm dyskinetic. So all I saw was almost color coded. I saw the check marks when she took her medicine, when she ate. It was all documented there several days. And she pointed, she said, look, this is a bad day. Look at all that purple and look at all that red. I said, yeah, that's a tough day. And she said, and this is a good day. I got a lot of green, very little purple, very little red, but I'm having more of those bad days than I am good days. What can I do? I said, well, deep brain stimulation absolutely is an option for you. Thinking about surgical treatment modalities, once we've kind of utilized our medication regimen, can be very, very helpful. Remember, off time is not uncommon. You see, this MJF Foundation study showed that greater than 90% of patients with Parkinson's disease have off time. And under 5 years after diagnosis or initiation of levodopa, you can still see about half of the patients experiencing off time. So screening for off time is a very important treatment strategy, screening strategy to determine whether or not we should take that next step and either adjust medicines or consider DBS. So how do I optimize on time? And how do I minimize off time? We talk about dopamine, how important it is. You saw the striatum and the areas that have low dopamine transporters indicative of low dopamine levels. So what can we do? We have to use medicines. Try to use medicines that might reduce those fluctuations. Use adjunctive drugs. We might use medicines like a monoamine oxidase inhibitor, a dopamine agonist. We might use a COMT inhibitor or an A2A receptor antagonist in addition to our carbidopa levodopa regimen. We might convert to extended release formulations of levodopa. We may consider on-demand treatment options. Those are all the things that we can do. DBS has been established as an effective therapy for over 20 years. And DBS has had the largest effect on quality of life among all treatments. There was a landmark study that looked at quality of life metrics and showed that quality of life metrics improved tremendously after deep brain stimulation. Sorry, next slide. I think Sam is frozen. Okay, so we may have lost Sam, but in the meantime, what I'm gonna talk about here. Hold on one second. Be right
I think
there.
she's coming back.
Hey Sam, you're back.
I'm sorry.
It's okay. It's perfect. We needed an intermission because we were between
Okay, yeah,
our
fine.
sections anyway.
Okay.
And we have so many wonderful videos that I think our group here we were affecting the bandwidth.
Okay. Can you guys see it?
Yes, beautiful.
Okay, cool.
So, oh, perfect timing. So it was a good intermission. Hopefully everyone had a break. And you had a little a moment of a break before we dive into the better part of this presentation is, so what are we going to do about it? So it reminds me of my mom's always used to tell me, if you're going to come up with a problem, you better think of a solution for that problem, right? And so now we've identified all the problems, all the things that can go wrong. But now this is the moment where we talk about how to make it right. We saw patient in an off state, in an on state, dyskinetic. We talked about the treatment options, but let's talk about DBS a little bit. So the initial discovery, in fact, about stimulating brain regions goes back all the way to the 1930s. So I can't believe it, but the 1930s are now close to 100 years ago. That was back in the times where neurosurgeons, in fact, prior to implanting electrodes, used to use what's called lesioning techniques to treat Parkinson's. They would either cauterize or essentially create a lesion in the brain, in the circuitry, to see if things improved. It wasn't until the 1990s, late 1990s, where DBS received full FDA approval. And then when the Abbott system became available, we saw that there was, in fact, a directional deep brain stimulation system, which allowed us not just to create a spherical electric field around those contacts, but what was unique to the Abbott system was that in 2015, post 2015, we were able to direct the electric field in different directions. And that was called directional stimulation. And it allowed us to more effectively focus on an area. Remember, those areas in the brain are really small, in fact, and we didn't necessarily need such big electric fields. And what it allowed us to do was really focus our field with directionality, target the area of the brain that we needed targeting without hitting the adjacent structures that sometimes would cause side effects. So the Abbott system is called the Infinity system. You can see this patient that has Parkinson's disease with a tremor. Look at the profoundness of that tremor in her right hand. Now, this patient already does have deep brain stimulation. Her stimulation is off, and we're going to show you kind of a drastic difference between the electrical stimulation being on versus off. And right now, these are her symptoms. These are her symptoms without the electrical stimulation. You can see it's a pretty profound tremor that you see both on the right and left side of her body. And you can imagine, how a treatment option like deep brain stimulation with Abbott's Infinity DBS system, after you turn it on, if you can get rid of a tremor like that, imagine the quality of life improvement you're seeing in that patient. Look how steady her hands are. So this is a good question from Judy, and is the same area affected for all Parkinson's patients? And that's a really, really important question, because there are different targets in the brain for deep brain stimulation, meaning different areas that need stimulation. It's very much based on the patient's symptoms. So if a patient has a tremor-dominant Parkinson's disease, not a rigidity-dominant Parkinson's disease, and they are on high doses of medicines, and they're experiencing off episodes, and they're levodopa responsive, the subthalamic nucleus may be a very important area to target. That's a part of the brain where we can implant the electrode. But there are patients that don't have tremor predominant Parkinsonism and have a lot of gait impairment or profound dyskinesias or profound stiffness and rigidity. In those patients, it may be more beneficial to target the globus pallidus, another part of the brain that may be a better target. Not far away from the subthalamic nucleus. Those are the different parts of the brain that we can target, because those are the different brain regions that, if you kind of can create an electric field around, can really kind of target the symptoms. Remember, it's based on each patient and what symptoms they're experiencing. So deep brain stimulation, in fact, is effective for movement disorders because it provides more hours of quality on time and better control of motor symptoms. During reduced off time, reduced reliance on medication. In many cases, we can reduce the overall dose of levodopa in these patients by more than 60%. So the actual cumulative dose of levodopa can be reduced. And we can see reduced dyskinesias and fluctuations, right? Improved on time, reduced off time, and less reliance on oral medicines to provide an improvement in on time and reduction of off time. And hopefully a reduction in troublesome dyskinesias. We think of deep brain stimulation as an electrical version of medicine, an electrical version of dopamine. The stimulation also, when you go see your movement disorders doctor after the neurosurgeon implanting the electrodes, the movement disorders doctor can make field adjustments, electric field adjustments, can create different programs, different groups, one that might target tremor better and one that might salvage your gait a little bit more than another group. And you can even create your own system within your mind as a patient and go up and down on the amplitude and take control of the stimulation and switch from group to group if needed. So the symptoms that respond best to DBS are tremor, rigidity, bradykinesia, which is slowness of movement, akinesia, which is almost lack of movement, and dyskinesia, which is the uncontrollable movements that happen. Symptoms that respond well to levodopa often improve with DBS, which is why understanding what sort of improvement you see with your best on. I always ask patients thinking about DBS, they say, well, what should I expect? I said, well, consider your best on. What do you feel? Do you see improvements of those symptoms on the left, or do you not? Most of the time, when we don't see symptom improvement with levodopa, then we shouldn't expect to see symptom improvement as much with electrical stimulation. But if we do see symptom improvement with levodopa, that's the expectation of what the electrical stimulation can give us. That improved on time throughout the day and reduced off time. Symptoms that might not respond so much to DBS: speech dysfunction, swallowing, the micrographia or small handwriting, postural instability, and freezing of gait. So how do you know if you're a good candidate? Well, in the past, we used to say, if you have Parkinson's disease that responds to levodopa and you've had it for more than 4 years, then you may be a good candidate, because beyond 4 years is oftentimes where we might see the ebbing and flowing of the medicines. So there's no significant cognitive impairment in patients. We want to make sure that cognitive impairment doesn't exist, and that overall the oral therapies have been tried, and we've tried to create that stability, but we haven't been able to. That's how we find a good candidate. It's not uncommon for us to do a neuropsychological evaluation in patients to make sure that there's no cognitive impairment to begin with, which is also why we do say that there may be a time period in which DBS, almost like a window of time where we can do DBS. And if something were to change with cognitive impairment, then unfortunately, we would lose that candidacy for DBS. So what does the procedure look like? And it's important to know what we're in for. And let's see. This is a patient. You're going to see stimulation on and off, and how it is that they utilize. Look how they're utilizing. This is their device. Essentially, it's a touch screen, right, that you carry with you. And you can see with the stimulation off, this is another patient that unfortunately has Parkinsonian tremor, and it's worse on the left than the right. But look how hard it is for him to do finger tapping. And look at the tremor there. He's trying to touch his nose, and it's hard for him. He's losing that fine coordination. On the left, he's trying to do what are called rapid alternating movements, and that's very difficult for him as well. Let's turn on the device, and let's see what it looks like. And look how he does it. He just turns it on. He taps on his touch screen there. He's holding that. And as the electrical field sets in, you can see the improvement of tremor and other features, right? It might be easier for him to do finger tap. His fine coordination may improve. Maybe his gait's impaired when he has it off. Let's take a look here. Oh, in this case, he's suffering from, pretty profound tremor there, right? So hard for him with that right hand. Now he's going to turn it back on. And you can see just one tap on the touch screen. It's taking some time, but it's setting in. You can see, look how that tremor has improved. And the technology, just since I was trained, so I was trained between 2015 and 2017, right around the time where the Abbott system became more and more available. And I can tell you, before 2015, there has been so much improvement in the user interface of our devices, in the technologies for deep brain stimulation. And I think Abbott really pioneered that improved user interface that made it, from a movement disorders side, programming became very straightforward using our device. And then for patients, it became so much easier to use a touch screen like that to turn on and off the device. What we're seeing here is that DBS therapy works by creating an electric pulse or an electric field. And that field essentially is targeting those parts of the brain. And that stimulation stabilizes the brain signals that cause the problems. So there might be these brain signals or the circuitry that needs a disruption with an electric field. And that's the way we think about it. We create an electric field to stabilize the signaling within the brain. You can see there that the electrode is implanted in the brain, but there's a wire, in fact, that comes down behind the ear, under the skin. Nothing is visible. And then the impulse generator or the battery, in fact, sits usually on the right side of the chest wall. And that's what it looks like. That's what we would have implanted after deep brain stimulation surgery. So DBS procedure, there's different stages. The first stage is imaging and planning with an MRI, implanting the lead with neurosurgery, making sure that we've implanted the lead in the right part of the brain, utilizing different techniques like hearing and seeing the electrical activity of the brain while in the intraoperative suite, and then securing the lead and then closing up, because what's made are two burr holes, which are small holes in the skull that are then closed up after the electrodes are implanted. Then the next stage, it happens afterwards. It's a different appointment. You'll run that extension, that wiring all the way down behind the ear to the battery with an impulse generator. And then the implant battery, the battery's implanted and then sutured up and closed on the skin. So after implantation, usually 3 to 5 weeks after procedure, that's when you come see your movement disorders doctor, your trusty movement disorders doctor that's been hopefully supporting you and guiding you through this entire process. And we will create the electric field that suits the symptoms of each patient. How is it, depending on, hey, should we target gait? Are we seeing more symptoms in the face and arms or more in the trunk and the legs? There is somatotopic mapping and a reasoning behind how we can create electric fields. We can focus on the arm, we can focus on the leg, and that does take time. And and choosing the electrodes that give us the best benefit with the least side effects are very, very important. It could be several hours that you might spend with your movement disorders doctor. Hopefully your doctors aren't late to see you, but if they are, remember, they might be in a really complex case and they might be doing a lot of things to try and help someone else. You never know, you got to keep trying and being persistent. So what about cost and coverage? In fact, cost and coverage is not something that we are very concerned about as clinicians that prescribe it. In fact, most public and private health insurance plans, including Medicare, cover and approve deep brain stimulation for Parkinson's disease treatment. It's important to call our insurance company and see, what sort of plans we have and if deep brain stimulation is covered, of course. But what I can tell you anecdotally, as in clinical practice, is, we've had over 20 years of success with deep brain stimulation, maybe even longer. And I don't know of an insurance plan that won't cover deep brain stimulation. So it's important to understand that side effects can occur. Of course, surgical procedural adverse events post-operative can occur. You have to think about all of the things that happen post-operatively, things like infection, bleeding, and other things that can happen after implanting a lead. Things can happen like stroke or other things that can be part of deep brain stimulation, the procedure being placed. Generally speaking, we have to make sure that also that our patient is not having depression, because depression or uncontrolled depression, a patient, if we implant deep brain stimulation in someone that may be depressed, there's a long period of time where we may start planning for deep brain stimulation and we start screening for all of these things, cognitive impairment and other things like depression. But these are the types of things that we look out for and we screen. And that's why it's important to really, really know who may or may not be a candidate and to start talking about it as early as possible, learning about it. Things like this through maps to be able to learn more about deep brain stimulation can be really, really helpful. Because the more we know, the more we learn, the more we might feel comfortable with it. We see videos like this of what it actually looks like to have a DBS on versus off. It can be very, very informative. Let's look at this patient who has the deep brain stimulator turned off. And let's see that patient walk down the hall. You see, we're seeing difficulty with gait. Patient has gait impairment. It's hard for him to turn. He has reduced arm swing. It's hard for him to lift up his legs. His symptoms are uncontrolled. His Parkinson's symptoms are really affecting his gait. He's using a cane. Now let's see it. Wow. So he's not using a cane. He's got a really cool shirt on. I think he's like, let me show you what maybe he's able to go do things that he really enjoys to do. That he look at him swing his arms, look at his big smile, So the electrical stimulation, I hope you were able to appreciate that contrast between the stimulation being off versus the stimulation being on. I mean, he was using a cane. It was so hard for him to turn. And then you saw how quickly he was walking with his arms swinging and everything. So let's talk about Abbott's advancements for deep brain stimulation therapy. So the Abbott system is called the Infinity DBS system. And you can see all the components here. When we talk about the surgical treatment and how it works, remember, you see there that number one really is showing you it's a burr hole cap that secures the lead in place. That's what really holds the lead. That lead is basically the electrode that's implanted in the brain. But you can see the system also includes a stimulator that powers the system. Remember that impulse generator and stimulator that powers the system is an important part of it. In fact, over time, we may need to replace the battery. In fact, directional stimulation has allowed for us to find a lower constant current to get a very similar improvement, a positive impact, thereby extending the duration of the battery life so that we don't need to change it as often. An extension is also part of it. Remember that extension between the actual electrode, right where that burr hole the cover comes out underneath to connect to the impulse generator in the chest wall. And then we have a clinician programmer and a patient controller. So in fact, what a very unique thing from the Abbott Infinity DBS system is that we can even program patients remotely. So you may be as a patient at home and I may be in clinic, and I might need to make a small adjustment without having you have to come in and wait all day long for your doctor, or come into your appointment and say, but we can do it remotely, just like we're doing this presentation. So I would open my clinician programmer, and then our patient would open their patient controller, and we may have a discussion about what symptoms need fine-tuning. Oftentimes, wonderful Samantha, who's all over the DMV area and the Baltimore area, taking care of patients like our proxy. I mean, what Judy said is absolutely true. Samantha's a wonderful person. She cares about patients, and she helps us, troubleshoot and coordinate and speak with patients. She's probably always available. It's almost like at any moment I say, Sam, I need your help with this one thing. Can you? And she goes, absolutely, let's go. So she's really your support. But so she may sometimes help us with setting up the remote programming. And once we do it, it can be very, very helpful to be able to program our patients anywhere they are, especially not having to come into the clinic. And then we have our leads. You can see the leads that are implanted that are actually embedded in the brain in those different brain regions. So what's important, let's visualize directional stimulation. It was at the time in 2015, and still is a revolutionary directional lead that allowed for us to target specific areas without having to go all throughout the entire sphere. We could target in one direction, another direction, and 3 directions throughout the brain. And there are more therapeutic options to help maximize on time and limit side effects by doing that. And let's show you what that looks like. So you can see that red is essentially the electric field, and you can see how we can essentially turn that electric field so as to be able to target the area of interest. The real strategy and the science behind programming DBS is to be able to target the brain region that's affected most and steer away from the adjacent structures in the brain that can sometimes lead to some of those electrical side effects, the side effects from the electrical stimulation. So if we think about how it is that we learned about directional stimulation, the landmark article was called the Progress Study. It was a big study. It was the largest directional DBS study, and showed that 9 out of 10 Parkinson's disease patients could benefit from Abbott's directional DBS compared to conventional non-directional DBS. Patients were less likely to experience complications. DBS system using directionality with the Abbott system allowed for us to have less complications from the electrical stimulation. So what's the sort of experience that fits our lifestyle that we should be expecting? When we think about it, it's really the freedom of being able to control our day, to be able to have that electrical stimulation that has a recharge-free battery, so you don't have to recharge the battery. And because sometimes we might use directional stimulation, you may have a longer battery life. You can control your everyday. So regaining that control by increasing the amplitude or adjusting the programs from program to program, as the movement disorders doctor may do, and unlocking the potential for future, what we can do moving forward. We have constant updates and different things that are available. There are software updates, and then the MRI compatibility using deep brain stimulation with the Abbott system is very, very important in case we may need an MRI. So what can we do using the Neurosphere digital care platform? You have that patient controller, you have that device that's a touch screen. Remember, you can essentially control your own modulation. Once you get to know how to utilize it, we may be able to talk about when to go up on the stimulation or when to go down and when to use which group versus another group. But essentially, you're using an iPod Touch device, and you can see here, you may be at a certain stimulation. You see here that 2.4 number and the 1.4 number. That's the amplitude of electric stimulation. Here you see the therapy is on, but it's a user interface that's simple but also very effective. And we talked about virtual clinic, but that remote clinic that allows us to just have Sam in one place and with maybe the patient or with me, and the patient be at home. I remember my most recent case was a patient. We had done programming at their initial visit, but then a month later said, I'm feeling great, but I just have a little bit of a tremor that's still there. And Sam and I set everything up and we did remote programming. He didn't have to drive 3 hours to come see us. And we got rid of the tremor while he was sitting in his house. All we did was had to make a small fine-tune adjustment to the DBS, but we did it remotely. And staying connected. Look, nowadays with virtual presentations and virtual appointments, and we call ours our electronic appointment. You see that we can do a lot from video, including deep brain stimulation adjustments, only with the Abbott system. You have to first establish a secure connection, of course, to Wi-Fi to get that virtual care set up. That's where Sam becomes very important to set up, make sure that we're all registered properly with the proper identifiers. And Olson, this story essentially was that he chose to utilize deep brain stimulation with the Abbott system, and he was able to control his symptoms and improve his quality of life in the process. So thank you so much. If you have a question, there's if you want more, if you have more questions and want to learn more about how to proceed, that's a QR code. If you take your camera and you open your camera and you tap on the screen of your phone, that's how you open a QR code, and it can open an important website on your phone to learn more. But really, Sam is a wonderful resource. She knows so much and about the Abbott system and about deep brain stimulation. She helps set up all these programs. Judy and Michael, of course, are very important for all of these presentations and resources. So thank you all for listening on a Tuesday night. Judy, thank you for being so awesome and making this happen. I'm so excited that I was able to talk to everybody else on this video call.
So I have some questions, although I think you might have answered questions that were submitted earlier, but I think you might have answered them. I'm just going to say what they are, and then you can answer or not.
Absolutely.
What are the benefits of deep brain stimulation?
Okay, so the main benefit of deep brain stimulation is basically that you can use electrical field stimulation and essentially prolong that on time while reducing your reliance on the dosing of levodopa. So you don't need your medicine as frequently. You can lower your levels of medicines and your cumulative doses, and you have stability because you're getting that constant electrical stimulation to the brain.
Can DBS change your personality?
Well, it's important, because the brain is a complex organ. So it's important to recognize whether or not depression is uncontrolled and exists, because there have been reports of patients with deep brain stimulation and it affecting or enhancing depression. So we have to make sure that we've done everything to ensure that the candidacy is as optimal as it should be, ruling out uncontrolled depression and ruling out cognitive impairment. Those are important things that we need to make sure before we determine whether or not someone's a candidate.
Internet is going in and out again. Let's see. I wonder what a better way to do this is. Can you hear me?
Now it's perfect.
Now, okay, I'll do this fast then. Does DBS help with fatigue?
Well, I think DBS can help with the symptoms of Parkinson's disease and reducing off time and improving on time. So it may have an indirect effect on fatigue if fatigue is related to an off episode. So if you can improve off time, then it's possible that we can improve the symptoms of off time. That said, there are symptoms that are better controlled with DBS and symptoms that are not as well controlled with DBS. It's really those symptoms that we talked about, like the tremor, rigidity, and some of the other bradykinesia and some of those features that we really believe deep brain stimulation can be effective to treat.
Does a surgeon have to do the implantation, or does my movement disorder specialist do it?
You bet. It's a team approach, and that's where Samantha's she's an integral part of that team. In fact, the account executives or the representatives of Abbott, in fact, are part of the process of many surgeries with the neurosurgeon, and our neurosurgeons are the ones that do all the staging and mapping and implant the electrodes, and all the surgical bits are done by neurosurgery, and all the programming is done by your movement disorders team.
Let's see. Does DBS, I think you've answered this, but does DBS help with the less stable walking and moving?
Yeah, well, you saw with that one patient with DBS turned off, how difficult it was for him to walk. He was holding a cane. It was hard for him to turn. So absolutely, we can see improvement. We don't always see improvement in certain aspects of gait, like freezing of gait or other things. But you could see in that one patient, the bradykinesia was improved, and patient's ability to lift his feet off the ground and take bigger strides and turn more easily and not use a cane was very visible after deep brain stimulation was turned back on.
One last question. If you had to compare DBS to the non-surgical DBS, the one that's less invasive, how would you compare?
I'm not sure. So the answer to that is there's been no head-to-head trials with deep brain stimulation and I think what the question may be about the MRI focused ultrasound.
Yeah.
Which is non-invasive in terms of the way it's performed. But the MRI focused ultrasound is a type of procedure that causes a lesion in the brain using high frequency ultrasound. There's been no head-to-head studies, meaning comparing the two. But what I can tell you is that deep brain stimulation has been around for 20 years or more, since the late 1990s. The electrical stimulation can be programmed and adjusted, and we can evolve our electrical stimulation with the evolution of symptoms at times. And so deep brain stimulation in many ways is a tool we use because it's not uncommon for us to have to make adjustments. So the ability to kind of control the stimulation, and for me as a clinician to be able to adjust, also is very important for an ever-evolving condition.
Okay, I think that was the last question. Excuse me. I think it was. Thank you. Thank you very, very much.
Thank you.
Sam, do you want to speak so you can tell them where your information is? Yeah.
Yep. So I am your area representative. So I work with all the patients, all the doctors, all the surgeons, and try to help everyone come together. I put my contact information in the chat. So if anyone would like to reach out to me for any questions or any help, I'm more than happy to.
Also, this is being recorded, so it will be on the MAPS website in a day or two. Michael? Yes? Yeah, okay, a day or two. Anyway, by the end of the week, how's that? By the end of the week. And I hope everybody enjoyed. I know I always enjoy YASAR, Dr. Yaghi, and this was actually really, they're always interesting, but this one was more so. So thank you.
Thank you, Judy. It's always a pleasure. Thank you for the opportunity. And thank you, everybody, for listening. What a great program.
Thank you.
Bye-bye.
Night, everybody.
Bye-bye.